appreciate all of the rest of you's time. So today is kind of the first content-based session. And the goal of these sessions is to cover various topics in primary palliative care, sort of build the whole team's comfort with some of these skills and ability to kind of think about things from a quality of life, a primary palliative care perspective. Let me see, if you're not muted, if you don't mind going ahead and muting yourself. So with that, I'm going to actually turn it over to Shaina to get started, and then Brandi and I will be jumping in for other portions of this first talk, which is on mental health and symptom management for depression and anxiety.
Hi, everybody. So I just want to mention that these slides are adapted from the Train the Trainer modules that are a part of this project. We tried to adapt them in a way that took into consideration some aspects of how we deliver care at our center, and using a case example that's kind of a compilation from some actual patients of ours. So primary palliative care for depression and anxiety. Psychological symptom management is one component of primary palliative care, and that goal is to reduce distress and improve quality of life. And primary palliative care interventions we want to consider across disciplines, and so this is a bit of a change. We've been doing mental health implementation for a long time. So part of the emphasis here is looking at how we can do this more holistically as a team and developing comprehensive treatment plans in these areas listed. So screening and education, lifestyle modification, psychosocial interventions, integrative interventions, medical management, and then thinking about when to refer to specialists. And so we've kind of noted some of the disciplines out here. You know, none of this is super rigid. It's just sort of a suggestion to kind of get us thinking. These are our learning objectives. You know, what's the role of the multidisciplinary team in eliciting mental health concerns? We want to understand the symptom presentation of depression and anxiety in a biopsychosocial context. You know, what are the factors that contribute and play into that? And then develop and implement treatment plans for mental health concerns with medical and non-medical interdisciplinary interventions. And these are our practice objectives. So, you know, there's the content that we want to present, and then there's what we want to do with that in terms of, you know, how we want it to influence how we practice and deliver care. And so we want all team members to utilize non-medical primary palliative care interventions that are appropriate and within the scope of their discipline. And then for providers, APPs, social workers, and myself, we will probably be doing more of the discussing why mental health treatment is important and providing hope, recommending timely therapy and medication as first line, particularly for people who present with severe symptoms of depression and anxieties, maybe in some cases prescribe or initiate, and then provide CF-specific recommendations when outside care providers are involved. And I would usually be involved in that kind of care coordination process. A lot of this we already do. We already have a process for doing this, and there are some opportunities to broaden this out. So our agenda is we're going to look at a case scenario and think through that together. This is where the interaction is going to take place. We're going to look at the recommended screening tools from the Models of Palliative Care Guidelines, have our case discussion and report out to the larger group together. We're going to look at clinical management, which is a little bit of a deeper dive. And then we'll look at resources. Fortunately, we're not doing this on our own. Our system over the last 4 or 5 years has come along and what they're able to provide to us and for what we can access to support the care of our patients. So our case is a 13-year-old Sophia, and she is presenting for routine follow-up. Her baseline medical status, she was diagnosed at newborn screen. Her FEV1% predicted at this visit is 74%. Her baseline is 79. She's been in the B zone when we sort of look at her rate of decline. She's not eligible for modulator therapy. And at this visit, she's reporting using albuterol every 4 hours for perceived shortness of breath while awake. Her BMI is 19. She's in the 20th percentile. And based on her most recent labs, she has vitamin D deficiency. At her last visit 3 months ago, she did her annual mental health screening and her scores were mild on the PHQ-9 and GAD-7 with no suicidal ideation and no previous history of mental health treatment. Psychosocially, she resides with her grandparents. They have had guardianship since age 11. She has a biological brother without CF. Her grandfather is especially involved in aspects of her CF care. Mom lives outside the home, has a history of diagnosed but untreated bipolar disorder and substance misuse disorder, and she recently began visiting sporadically. The last 3 months, she and her grandparents report increased stress and worry, difficulty with concentration at school, resulting in poor grades. In terms of her CF treatment, she's forgetting her oral medications, enzymes, vitamins, sleeping a lot after school, which disrupts nighttime sleep, and then missing her PM treatments. In clinic, what's observed during the visit is that she effectively appears anxious. She has a tearful affect. She's sort of fidgeting, bouncing up and down, having a hard time staying still, or maintaining eye contact. And like a lot of our kiddos with anxiety, she bites her fingernails and kind of.
Can I interrupt real quick, please?
Yes.
Oh, if you go back one slide.
Mm-hmm.
Could you give a quick reminder of what the 9 on the PHQ and the 7 on the GAD score is? That, I'm not familiar enough to know what that means.
Yes, that's a great question. And we are actually going to look at an example of Sophia's answered items. So we have a slide that has the items of the PHQ-9, but it is the suicidality question. For the last 2 weeks, I've had thoughts that I'd be better off dead or hurting myself in some way. But we will look at that, and that's a great question. And okay, and then the other part of what we're doing this visit, we are implementing the annual palliative screening, which is the IPOS screener for patients 12 plus, and then the caregiver screening, which is the BASC, and we're going to look at these screening examples. Okay, so this is not a full IPOS that you're seeing, but these are 3 questions, and so we're kind of targeting this for the case example. And so we can see here that she's indicating occasional feelings of being anxious or worried about illness or treatment, having sometimes some difficulty with friends or family being anxious about her, and then most of the time she's indicating having felt depressed. So this is where Brandi is going to kind of get us going in the chat. So the questions for you all, and this is where we want you to just kind of put your thoughts in the chat. What items are important to explore further? What stands out to you based on what you see? What are the next steps in assessment?
All right, I'm waiting. We'll see how fast people can type.
And if anybody's brave enough, you can just call out your thoughts. I think that's probably okay too.
Yeah, absolutely. And also remember, we're just asking you to think, within your discipline too. So what are you thinking that you'd want to explore further?
I would guess, this is Matt Hazen again, just any changes in the home or school situation. Either divorce or grades or, pressures with school, that sort of thing. She's 13, so that means she's in middle school or possibly 9th grade. And so I dreaded her. I have still bad memories of middle school myself. So I was involved with that.
So you're already thinking about, like, what's the context? What are those biopsychosocial contributors, that where this might be happening or what factors might be contributing to this. That's exactly. So I want to just note, so this is from the guidelines. The recommendation when using the IPOS is to look at the items of the greatest frequency or severity. So on this example, we'd probably kind of start with the, have you been feeling depressed item and use that as sort of, this is what we need to explore further. And so the palliative screening guidelines recommend that when depression or anxiety are indicated as a primary point of distress on the IPOS, that we kind of fall back to using the PHQ-9 and GAD-7 again. And we already have a process for doing that. In Sophia's case, because she had mild scores at her last visit, she would already require a repeat screening for monitoring based on the guidelines anyway. So the mental health and palliative guidelines, are kind of aligning here. And so here we are with her GAD-7 items. And so again, looking at here, we see a moderate score. So moderate severity of symptoms. And so what stands out to you here? What observations? I know this might be sort of hard to see on your screen. And again, you can put it in the chat or just call out. So I would just reflect that, kind of based on the observation, what you're sort of seeing of Sophia in clinic, that these items and their responses probably wouldn't be terribly surprising, so her responses on the screener and your observation of what's happening in clinic are consistent. I'm going to go ahead and move on to the PHQ-9. So this is her PHQ-9 responses. And so yes, we can see down here on item 9, thoughts that you would be better off dead or hurting yourself. She's had several days of experiencing those thoughts over the last 2 weeks of time. We also see here that she's having some somatic symptoms, difficulty with sleep, feeling tired, low energy. The first 2 items of the PHQ-9 are really the core symptoms of depression, feeling down, depressed, or hopeless, loss of pleasure. So anytime somebody is scoring, high on these 2 items, we really want to pay attention. So what's the next step? So we have a positive response on item 9. So what does that mean?
And Shaina, can you read off the question for item 9, like what it actually says?
Item 9 says, thoughts that you'd be better off dead or hurting yourself in some way. And she's saying her response, sorry about that, is several days. So she's experiencing these thoughts for several days.
Oh, and I hear it's on the chat, someone says you need a safety plan. Eileen says, ask if she has a plan, a scale of 1 to 10, how serious?
Okay.
Yeah, and this is Matt. The reason I keep speaking, by the way, I'm on my phone. It's a lot harder to type on my phone.
Yeah, go for it.
I think this is one of the things we have to decide if it's safe for her to leave the clinic.
Perfect. Yeah.
Yep, that's right. So within our system, we have a protocol for that. We have a system policy and a recommended screener to assess for that. And this is the AskQ. It's a validated tool used for kids 10 and over, and it's primarily been looked at in medical settings. So this is what we use at CHOA. And these questions are more poignant to the issue. In the past few weeks, have you wished you were dead? Which is different than thinking things would be easier if you were. And so in walking through the ask, so the ask is clinician administered verbally. So these questions would be walked through, and in Sophia's case, she's answering no. She does not have a previous history of plan or method preparations, previous history of attempts. So, these are indications that, the acute risks are that we can probably mediate those in the clinic setting. So over here to the left, I'm not going to spend a lot of time because we have a lot of material to go through, but this is an actual safety plan. We use a safety plan template that's commonly used in primary care settings. And so it's looking at how do we identify warning signs? We discussed that together. How can you cope? Who are the people that you can ask for help that you will ask? Who are the professionals available to you, and what can we do in the environment to mediate those risks? And, what are you looking forward to? You want to find out if a kid is able to be forward thinking, if they're saying, well, my birthday party is on Saturday and I'm really excited about that. That's a really positive indicator. Okay, so we're getting close to our breakout groups and we want to be sure to have time for that. So Dr. Hazen, you've very well kind of launched us into what do we need to be thinking about? So walking through the screenings here, the items themselves really help us to think about what are the symptom characteristics? What's the frequency? What's the indication of distress or impairment? So on the page Q9, we see down here at the very bottom that she's indicating that this is very difficult. And then we've already heard reports from her and her family indicating that school has been difficult. She's having trouble with her daily CF care. And then we have identified safety concerns. We'll get to this a little bit more in depth later. Many of our kids who fall in the moderate to severe range are often already established with providers. So we may have more history around what's helped, what are the resources available to them? Can we get them an appointment with their established therapist, by Friday and it's Wednesday? And, always part of the conversation is talking through patient family preference, thinking about access to care. So those are all important factors. Okay. Time to discuss. I'm going to kind of turn over to Brandi to kind of facilitate the breakout groups. And we have a couple of questions that we'll pose to you, and then we'll come back to the larger group and discuss together.
Right. Thank you, Shaina. So in just a minute, I am going to open all of the breakout rooms. I have the rooms named. There are 4 different rooms. They're reflective here of the breakout sessions. I also put Eileen in one of the rooms as well. You should move into a room automatically, but if you don't, there is an option that you can choose which room to go into. So just know that. We're going to have 10 minutes in our breakout rooms. And then we want you guys to be thinking through the question. I think that Shaina just went over a second ago. I'm going to actually post it in the chat, and then I'm going to send it to the breakout rooms. You should see it flash across the screen, but you'll see it in the chat right now. So what symptoms might your discipline generally observe during a routine CF clinic evaluation that might be indicators of anxiety and depression? We know that you guys see those. And then also, what non-medical and medical interventions could your discipline offer to Sophia? And thinking of all of the great things that you guys add, you all have something to offer here. So one other tip, when you come back, one person from your group is going to report back to the group. You're going to have about 90 seconds to succinctly tell us what you have for your answers for those 2 questions, and hopefully we can learn from the group as well. So I'm going to open the rooms, and you guys are going to apparate like in Harry Potter fashion, magically out there. All right, fingers crossed this works. All right. And a few people I'm still assigning. Let's see, Dr. Diaz. You're in providers.
Brandi, I may need you to reassign me because I just got on with my, oh, I got it.
I gotcha. I just saw you pop back up.
Thanks.
And let's see, Olivia, where should I put Olivia?
You could maybe go with the providers
With the providers. Okay. Got that going.
And Akel for research.
We're low on the RTs, and
Good point, Brandi. I wonder if there's a way to edit this out. You might have to get Kimmy involved.
Oh, you know what? I could probably pause.
Yeah.
All right. I'm resuming the recording. And I know everyone's coming back into the group. So I know it may have been hard in the groups to see the questions. They are in the chat again. And so let's see, Shaina, do you want to call on the actual groups, or do you want me to do that for?
If you will do that, and then
Alrighty.
I will kind of type in some of the input here on the slide.
Alrighty, awesome. Well, let's ask actually our room one, which was our registered dietitians that are so important to us. What did you guys come up with for what symptoms might your discipline generally observe during your routine CF clinic evaluation that might be indicators of anxiety and depression?
So changes in appetite,
Yeah.
stopping enzymes or any nutrition related therapies. I think those were, and a big change in the weight.
Yeah, perfect. And then what did you think about for medical and non-medical interventions that you might be able to offer?
So we as a group felt that if there was like a logistical issue, such as like waking up late and not eating or not having enough time to eat at lunch, things like that we could possibly help with in the 504 plan or speaking with the social worker. But from a mental health perspective, we do not feel equipped to help, and thus we would refer to the mental health coordinator or let the physician know or the social worker know.
That sounds good. So maybe more like practical things like, you know, what snacks to bring with you or ways to remember to take your enzymes or sounds good. Well, thank you for that.
Remember the one detail in this case, which was that Sophia's vitamin D is depleted.
Oh, she's muted. So
sorry. So we just realized that we forgot that we were thinking of it from a general perspective, and we did not think about Sophia in this case. And yes, I mean, vitamin D deficiency could definitely affect that. So we would try to help with that.
Yeah, and you guys are all over that in clinic, which I love. So, all right. Well, thank you for that, Conan. Let's see the second room. This had Eileen and Karen, our RTs as well. Who is your spokesperson?
I am the spokesperson.
Thank you, Eileen.
So we had kind of a lot of different specialties. So
yeah, you did.
An input. But I will adapt a little bit of what we talked about because we did do this sort of general as well. But from research for Akel, you know, she spends a lot of longer amounts of time with patients and finds that sometimes they are more casual or open up a little bit more about some of the feelings that they're having.
Yeah.
And so they may not look at her as like a provider who's, you know, putting this in their documentation or filling out a survey. So she often will hear things that are said to her and passes that along to the provider or the other clinicians or social worker. For Karen, Karen often is like the first line of identifying if someone she, you know, feels or has a change in mood because she can pick it up pretty quickly while doing their PFTs. So for her, she may notice, you know, not wanting to do a PFT or, you know, really not putting in the effort. So what she tries to do is sort of pep them up, try to at least get a couple of measurements. And then also she will pass that on to the other providers that she notices they may be feeling off and aren't putting in their full effort. Trying to keep it in 90 seconds. For me, it's a little harder because I only see patients maybe once or twice and may not pick up on mood changes that are typical for them. But in my intake for anyone of a certain age, I often ask those feelings. So if that comes up, I ask like, who do they feel supported by? Who do they talk to when they're feeling down? If they've ever considered therapy, things like that. But I do pass along to the provider as well, if there's something I've heard.
Yeah, I love it. I think it's a good point too, that if they're able to be in the place to talk about family planning with you or expanding their family, Eileen, it's probably a better place than being severely anxious or depressed.
Yeah. And I actually brought up the point that Dr. Linnemann said too. A lot of times it's not necessarily just the patient, but family members or parents expressing a lot of guilt from, passing down this genetic disorder, senses of like mourning. A lot of moms after birth can be dealing with a lot of that as well, and dads too. But the postpartum also plays a role. So identifying that and then passing that along to social work and asking like who they have to support them is my typical process.
Yeah, I like it. Thank you so much for synthesizing all of the disciplines together. I appreciate it. You did a great job. All right. Well, room 3 is social work, our nurses and MAs. Who is going to talk for that group?
I'll kind of start us off.
Awesome.
So nursing is generally that first line of contact with the patient. So we pick up on body language pretty well and have established relationship with the patients that maybe we notice if something's different going on. One of our beginning screening questions is always those questions of intent to harm yourself or others, and do you feel safe? And so that kind of opens the door to those kinds of conversations. A lot of times the patient might say one thing, but maybe their body language is different. So picking up on those kinds of cues to then pass along to the team, maybe with someone they trust more, that would be better for opening up for them. And as far as kind of interventions, I feel like nursing has a great opportunity to be present and doing those like simple things like touching someone's arm, like letting them know that you are here and you care for them. And then just really communicating that with the team, and our social workers are so great to be able to step in and have a lot of resources. So nursing might help coordinate whatever the provider and social work might think the best steps are going forward.
Yeah, I love that. I love that you're there to support them and listen, especially if they want to open up. So, so great points on that. I'm also wondering too, I've noticed sometimes with some of our young adults that you guys are the first people to notice when their refills aren't happening, or they're more sporadic, or there was a big lapse, which sometimes I think can really talk about not having enough energy to follow through on treatment. So that might be something as well. All right. Well, Megan, thank you so much for synthesizing all of your disciplines. And then last, we've got room 4, which are our advanced practice providers. So who is going to be the spokesperson for that group?
Hey, Brandi, it's Bree.
Hey, Bree. Thanks.
Hey.
Thanks for speaking for everybody.
Oh, sure. So some behaviors that we might see, like they're avoiding their care routine, like changes in their care routine and compliance, burnout with their regimen. They may be very jittery in the room, like shaking their feet or legs, biting their nails, lack of eye contact with you, or just being, not wanting to engage in conversation and kind of looking down. So dyspnea and using albuterol a lot, maybe avoiding relationships with and friends in school and stuff like that, might be some things that you see. And I think some things that we would do, just actively listen to them and, acknowledge, how they're feeling. We said, we could always get Shaina and social work involved, and maybe, a therapist for medication management. I think some of our doctors are comfortable with just starting an SSRI, like first level kind of thing, as either a way to we just manage that in general. And if they're doing well, we continue to management, or we put them on something like that until they can see, somebody to actually manage those medications. May look for vocal cord dysfunction, breathing treatments, maybe refer to the voice center if they're having some trouble with breathing and stuff like that. Going over coping techniques for, anxiety and depression.
Love it.
I think we have some CF yoga videos.
Yep.
And maybe get PT involved, getting them doing something that they really like to do.
Can I ask about the CF yoga real
yeah.
quick? Has anybody like used that with patients and found it to be successful, to be dismissive? I imagine a lot of families would hear that and be like, yoga. Has that been?
We have a video that we have a video I give them sometimes if they're interested in yoga, but I don't have lots of experience with it personally, but Amy might. I'm not sure if she's on this call.
I have some experience from back up at MGH with adults, finding it very helpful for both dyspnea and anxiety, but not so much experience with kids who've used it a lot.
Okay. And, making sure they're getting enough sleep, maybe starting some melatonin or either going a little bit above that. Shaina sometimes suggests some medications for sleep and stuff like that. And going over good sleep hygiene, recommendations for them.
That's important.
Yeah. And that's basically what we talked about in the short time we had.
Yeah, that was thorough. So thanks, Bree.
Sure.
Well, Shaina, I think you've got a good list going from all of our groups.
Yes, excellent. And we will kind of come back to Sophia's plan at the end, but this is an incredible start. Our time is limited, so I just want to give a forewarning that this next part is kind of a deeper dive into management. So if you have questions, post them in the chat or just speak up as we're going through. So it's just a lot to cover here. So what we did not want to do is tell you all, the DSM criteria for depression and anxiety. Most of us have a general awareness of that. What we want to sort of think about here in terms of symptoms, and most of you identified this very well, the core symptoms of anxiety obviously are feeling anxious, and Bree, what you're noting about avoidance, that's a core part of how anxiety manifests. So additional symptoms are things that we want to keep in mind. So mood shifts and transient anxiety are common developmentally in children. What you're seeing here on this slide is going to be more consistent with indicators that would be in a clinical range. And so that includes thinking about, how often this is occurring, how intense, how long has this been going on? So persistent somatic complaints, for example, I'm having a hard time seeing my slide here at the bottom. But, these are going to be the things that we want to be alert and aware of. Somatic complaints, stomach aches are the most common manifestation of anxiety in children, which can be complicated to tease out for kids with CF who have GI complications. We will have a module on GI, and we'll have some opportunity to talk through that a little bit more. Clinginess, regression, difficulty concentrating, restlessness, hyperactivity can also be part of depression, part of anxiety. And anxiety and ADHD also kind of co-occur together. So that can be part of the differential too. So
I just wanted to say, I love how all the disciplines talked about noticing the withdrawn affect. I mean, we heard RD talk about it, RT, the nurses, social work, every single person noticed that. So I think if we start to consider that and really bringing it to the team, it could be great just to start considering that. Yeah.
The other thing I appreciated is that there's an awareness between, what someone is telling us and what we're observing, the behavioral observation, and that, some awareness about that. So I think that's excellent. I think you all are amazing. We know that. So core symptoms of depression we've kind of covered in looking at the PHQ-9. So we want to think about, clinical depression is going to be persistent across situations and contexts. It's usually not going to happen just over here at school. It's going to happen across, different domains of someone's life. and changes in sleep, energy, or appetite that are beyond the usual CF fluctuations and usually can kind of be correlated with shifts in mood. Persistently decreased independence or ability to engage in CF care. And then I'm so glad Eileen, kind of talked about the excessive guilt and hopelessness. So some level of sadness and grief process is natural for people with CF. Even thoughts of death is something that is common to our population and not necessarily a clinical concern, but active thoughts of self-harm, extreme hopelessness, obviously that changes the picture. I'm not going to spend a lot of time here, but I am going to highlight from the case example, some of the differentials. So Sophia in this case has a first-line relative with a history of bipolar disorder. So that would be something to just kind of have your antennas up if we were thinking about initiating an SSRI. A side effect of an SSRI for someone who may have a disposition for bipolar disorder can be the onset of mania. So, and if we were looking at bipolar disorder, the management would be very different.
Can I ask a quick question about that real quick?
Yeah, yes.
If we are, as providers, thinking about starting an SSRI, it goes without saying, I guess, we should also give them resources for counseling of some type. And I know we have that, but can't just write a script and say, okay, treated, great.
Yes.
Check, next.
So, right. So I would hope that Missy or, social work would be involved. And usually for kids who are falling in this moderate severe range, I am pulled in and we'll kind of walk through the process for that. So I would be following, I might be part of the assessment, and kind of working together around a plan and some decision-making for that. So yes, and therapy is first line. For moderate to severe, we want to think about therapy and medication, particularly for those who are presenting with severe symptoms. I want to just mention ADHD because there are some US prospective studies that indicate that ADHD is more prevalent in people with CF. And then ADHD and anxiety can occur together. And so if we're having a hard time sort of teasing that out, or if that's a question, that might be a situation where we probably need to think about, referring a child to a pediatric psychiatrist. I'm just going to move through this. I'm not going to spend a lot of time here, but I just, we want to be aware that things like pain, dyspnea, sleep disturbance, these all influence and can trigger changes in mood or anxiety and kind of have this bi-directional relationship and its impact on mental health. Obviously, CF modulators. I listened to a session at a conference this year. There's a National Jewish and their group, looked at, they didn't have a lot of people come off of modulators for side effects. The ones that did come off of modulators, about 60% of them were because of mental health side effects. So that's just something to be aware of, that we have some kind of anecdotal data to suggest that there may be some indications there. We touched on these in the case example, so I'm not going to spend a lot of time here, but these are examples of lifestyle modifications that are good for everyone's overall mental health. These are things that we often do routinely, but that we might be more mindful to pull in as we start implementing primary palliative care. So I'm not going to go through this slide, but I wanted to include it just to demonstrate that this is the algorithm that we already use for kind of decision-making and care for depression, anxiety, anyway. So we already have a process for this. And you can kind of see here that for, moderate to severe, we're looking at an evidence-based psychotherapy as first line, and then, probably together with an SSRI. And on the left here, I just wanted to give some context that these are our screening data from 2021. So far, we've screened 144 kids, 12 plus, and 25 to 28% of those are falling within the clinical range. The moderate to severe group is, about 11%. So the Sophias in our clinic are not going to be a huge number of kids. And, we know that depression significantly impacts quality of life, the rate of pulmonary decline, and there's, some data to suggest that it's connected with mortality in CF.
Yeah, and we've also got a couple points in the chat that you can look at those. The scores are arranged on that last slide, and also that first line therapy and education, except for the severe range of depression, should be ideally for both medication and therapy.
And then over here, this is a big part of primary palliative care, is this whole section over here too. And so I've already touched on this with the algorithms, psychosocial interventions. We talked about some of these in the examples. And then I'm going to turn it over to Dr. Linnemann to walk through some of the medical management pieces.
So I wanted to just, you gave me a website that lists all of CHOA's recommendations for possible mental health, like counselors and the like, listed by county. You remember that's on CHOA's behavioral education website or something like that?
Yes.
First of all, thank you for that. I use it all the time in my non-CF clinics.
Good.
Do you know how up to date that site is?
It should be very up to date because their website just went live when they opened back in September, so it should be very recent.
Yeah, so I would encourage, if you don't know that website, I would encourage you to get it, because I've been able to, anytime I've got a patient who's asking for some sort of help, to look for mental health counseling, even the counselor by itself, it's been a great resource.
Yeah, and that we'll include that in the resources at the end. I will say, I know that I called this week and they already have a wait list for therapy for about 4 months. But for our CF patients, so I provide direct therapy through our clinic. So you can refer them to me, if they need to see someone locally, then I can work with them to, more personally and an individualized way work that out.
Great. So I'm going to jump in here and just briefly talk about medical management. Our goal, I think, for our clinic as providers, for most of us, is to be able to potentially prescribe something if we're comfortable in kind of severe or urgent situations, to bridge until we can find a more long-term psychiatrist, and also to be able to advise on CF specific things that the general psychiatrist may not, or nurse practitioner or psychiatric nurse practitioner may not know about. So for example, if appetite is a big issue as well as depression, to maybe think about Remeron. So that's just what kind of these next few slides go over. There's a lot of detail that's meant to be for reference on prescribing, so that if you are doing it for the first time, you can cite those things. So just to emphasize that last point Shaina made, for severe depression, we should be ideally offering both psychotherapy and pharmacotherapy. And certainly if we start with psychotherapy per family preference, and there's no or only partial response, to add pharmacotherapy. In adults, especially, pharmacotherapy may be used alone in situations where they're just not going to follow up with psychotherapy. Next slide. And once we start any of those medicines, of course, and even if we don't start medicines, we want to sequentially monitor response, and Shaina and our social workers can be a huge help with that, with serial evaluations. And then if they have an incomplete response to a starting dose, again, this is where we may be involving consultants, but think about increasing the dose, switching to a different medicine, or augmenting with a second class of medicines. One thing that we want to be sure everyone's aware of is that Shaina is willing to do any of that follow-up. So if you are starting a new medicine, just let Shaina know, and she will reach out over the phone in 2 to 4 weeks to make sure they're doing well, not having any concerns for suicidality. Some of the things that you might do in a primary care setting where you actually ask the patient to come back that visit that we may not be able to manage. So she can help assist us with that follow-up while waiting for a psychiatrist. Next slide. The other thing I wanted to mention is if we are starting a medicine, the up-to-date handouts for patients are really great. We don't do this that often, so we may forget about some of the side effects to watch for. And you can just print in clinic like the Celexa up-to-date handout, and it's going to go over, watch out for sexual side effects, watch out for GI distress or headache. So those can be a really great resource. In general, first line is an SSRI, and they are helpful for both anxiety and depression. I'm not going to go into the details of the comments here, but the most important two things to watch out for are QTC prolongation, especially if they're on azithromycin, as well as Cipro, for example, and then serotonin syndrome with linezolid. Next slide. These are the starting doses, and there's a document that will also circulate to the providers that goes over this in more detail, but they generally recommend starting low and titrating up, and continuing therapy for about a year before thinking about weaning. Next slide. These are additional medicines that target both anxiety and depression, and may be good. The SNRI class may be especially good if they're having comorbid pain or diabetic neuropathy. And then mirtazapine or Remeron can be especially useful for weight gain, appetite, or poor sleep, and also doesn't have any sexual side effects. Next slide. These are medicines just for targeting anxiety. So the gabapentinoids, and those can also be good for pain, neuropathic pain, hydroxyzine, which can be good for poor sleep, and then in rare cases, the benzodiazepines, which of course have potential for addictions and need to be monitored closely. Next slide. Okay, I think this is back to you, Shaina, and it is 1:29. We probably have about 5 minutes left if people are able to stay on the line. And then we will also circulate the slides and the recording, and we'll plan to start CF Learning Network meeting about 5 minutes late.
Okay, I think we've touched on a lot of this already, just talking through the case, situations where we'd want to refer to a specialist. I often tell parents if we are concerned about, multiple mental health diagnoses or teasing those out, like if we're pretty sure a kid already has history of ADHD and then we're seeing a spike in anxiety or an onset of mood disorder, those are situations where personally I think child psychiatry is warranted. And so in the case example, we've also kind of identified where there may be opportunity to pull in specialists. So Dr. Hazen kind of alluded to this. These are our internal resources. So we have our psychiatry consult liaisons at the hospitals who are available by phone. I call them a lot. They're very helpful. Myself, I'm here Tuesday and Friday on site. You can refer to me in Epic and Basket. Dr. Linnemann referred to the UpToDate resource in Epic. We also have sleep psychology here at CAP. So the outpatient behavioral health clinic over at the Chantilly location, which provides psychotherapy and psychiatry. They currently have a wait list for therapy, but not for psychiatry. And then what Dr. Hazen's referring to, and we can send this in the follow-up email, is a link on the CHOA website where you can find therapy providers by county. I know I've already used that. Social work, I'm sure, has been using that as well. And then PCP collaboration, your notes often go to the PCP's office. Sometimes if I'm seeing a kid for therapy, I'll send my notes to their PCP when the family has a helpful relationship. So this is a picture here of Sophia's kind of plan for intervention, and many of these things we noted already. Sleep hygiene, I'm just going to highlight maybe the things that we didn't, increasing time outdoors, encouraging structured routines, family dinner time, for example, starting an evidence-based therapy given the severity of her symptoms, which could be CBT or interpersonal therapy, school support since she's struggling at school. So what might that look like for her IEP or 504? Yoga, movement is helpful generally. Yoga has a lot of qualities to it that can help facilitate relaxation. Medical management, starting an SSRI would be appropriate because of severity. I think Bree already mentioned the kind of looking at not overusing albuterol, which can be kind of stimulating and might, in some ways contribute to anxiety. And then, who or the specialists that might be helpful to refer. And I'm going to just touch on this very, very briefly, but the other piece of this is the caregiver support. And so we have here an example of the caregiver screening. And so similarly, when we're working through these questions, and social work will be the one kind of facilitating this process, we're going to look at, which of the items are most severe or occurring most frequently and use that as the focus of conversations. And so in this case example, if the child is referred for therapy, there may be an opportunity for Sophia and her family to have some opportunities to work together, or the parent may be able to also receive some support through child or family therapy, or be referred for needs that they may have. So our caregiver screening and support, this is basically what we offer. So we want all of our team members to be able to practice active listening, use of empathy, normalizing the chronic demands of treatment. And then our caregiver screening packet includes resources for mental health, spiritual support, integrative resources that caregivers can tap into, and then practical self-care. And then we have a monthly caregiver support group that I facilitate. Okay, Brandi.
Yeah, and I'm just going to take 1 minute because I know Dr. Linnemann has talked about this before, that we have a lot of new resources that have really come about because of the grant that we have, the Improving Life with CF, the Palliative Care Grant. And what we know from people with CF and their families is that they want CF specific resources that are not just about generalized anxiety for people without CF. So there's going to be depression and anxiety best practice guides. There's also webinars that are being made available for everyone. So look for the resources. If you want to see them earlier, you can email either Dr. Linnemann or myself, and we can help get you plugged in with those resources, or you can look for some of our follow-up emails about that as well. So I just want to say that I really appreciated all the collaboration and everyone speaking out and talking with us. This may be one of the more interactive QI sessions we've had in pediatrics. And so I'm leaving with a smile on my face. So thanks for everybody for coming up with your great ideas, sharing your knowledge with us, and helping us learn from one another.
Thanks so much, Brandi. And I think this final slide is a great list of just key points that we're hoping you'll take away from this talk. We were so appreciative of everyone's participation. I think that was definitely the best part. So we'll send all these slides out, but just read through these key points. We won't read them to you. And have a great afternoon. Thanks,
Hi, everybody. Thanks so
Bye,
much.
everybody.
Thank you all. That was really interesting.
Oh, we're so glad you think so, Eileen.
Bye.
Bye.
Maybe multiple people, but I think that was great. I mean, I loved the discussion.
Yeah.
I think it's fine that we had to go a little faster through some of the content, because I think the discussion is really what